You're all set. You could share your screen.
All right, can you guys see this? All right, what's up, guys? My name is Usman Zarif. I'm a second year at Robert Wood. Today we're talking about distal radius anatomy. I know there's a lot of M1s that have not had anatomy yet, so we're going to start big picture. Every time you look at an anatomical picture, you want to get directionality down. So this is pretty obvious. We're looking at somebody from the front. I'm basically going to zoom in at this part. This is the arm. This is the forearm or the antebrachium. The antebrachium has two bones. There's an outer bone away from the midline, which is the radius bone, which is our focus for today. There's an inner bone, which is the medial, closer to the midline, which is the ulnar bone. And we're just sort of going to zoom in right here. Quick terminology: lateral means out, medial means in, distal means away from the trunk, proximal means closer to the trunk. And we'll do more of those quick anatomical terms just to keep everything straight. Okay, so this is proximal bone anatomy. We're looking at an elbow, and every time you look at a picture, like I said, we want to get straight what we're looking at. We're looking at someone's left elbow from the front. Just quick points here is that the lateral bone or the outer bone, which is the radius, has articulation. Articulation just means like where the bones join, which is the head of the radius articulates with the capitulum, which is the humerus bone, which is proximal bone in the arm. And then the radial tuberosity on the radius is just this little notch. It's going to go into the radial notch of the ulna, and the radius proximally is going to articulate with the ulna and the humerus bones. So there's three bones at the elbow, and that's sort of where we're at. Zooming in to just looking at these two bones, I guess what's important here is that the radius and the ulna articulate in two spots. There's a proximal radial ulnar joint and there's a distal radial ulnar joint. There's this interosseous membrane between the two. When you get into cadaver lab and you start feeling this, it's actually pretty hard. You can't really poke through it. And the point there is that these bones like rotate a lot on each other. So every time you go to hold a bowl of soup, or you do a reverse bicep curl or something, you're moving, and this movement is happening at the elbow. So you need some mobility here. Two things that I would like you to palpate on yourself is the styloid process of the radius. So that's on this side. If you just put your hand right here, you can feel that. That's the styloid process. Process on bones just means like certain prominences, certain bumps. And you can also feel from the back the styloid process of the ulna. So it's always I like to project on myself whatever diagram I'm looking at. I forgot to orient us. The picture on the left here is somebody's right forearm. Going distal, we can see that the radius articulates with the wrist, and it articulates with three of the carpal bones. So these are the wrist bones, and they're collectively called carpes. It can articulate with the scaphoid, lunate, and the tracheatrum. Well, it doesn't look like it does it with the tracheatrum. This, it's obvious, it's right in front of them, these two, scaphoid and lunate, but the radiocarpal joint extends to the tracheatrum, so it does articulate with the tracheatrum. Anything I want to mention here? I think that takes covered of this. So now we're looking at an X-ray, and I have to orient you because if the M1s haven't seen many of these. I told you the bigger bone at the wrist is the radius. The bigger bone at the elbow is the ulna. So even if this wasn't labeled and you can tell we're looking at a wrist, you know that this is the radius. And if somebody's hand is laying down like this and you're looking at it from the top, would this be the right arm or the left arm? It's the left arm. And this is the radius. That means the thumb is going up this way. That takes care of basically, I've oriented you. The radius is articulating with the scaphoid and lunate. There's a scaphoid fossa, a lunate fossa. There's the radial ulnar joint I mentioned. And these are the carpes. There's a trick for it. I'll just mention it now, and you'll have to memorize it later on. It goes so long the pinky, here comes the thumb, and it works really well because this is where the pinky's at. So long the pinky, I'm going to go to the thumb. Here comes the thumb, and it goes like scaphoid, lunate, tracheatrum, pisiform, hamate, capitate, trapezoid, trapezium. And the trapezium, I remember the trapezium is right under the thumb, and that's sort of my mnemonic for that. All right, we're going to talk about neurovasculature. I know the goal here is fracture and bone, but it's important to talk about these structures because these can get disrupted if you do have a fracture. So the brachial artery is the main supply to the arm. it's coming down. As it goes distal right at the elbow, it's going to divide into two arteries, the radial, which is on the radial side of your arm. This is where you feel the pulse on a patient, and the ulnar, and they're both going into the hand and supplying the hand. As for the neurovasculature, there's a thing called the brachial plexus up at the underarm, and it's going to send contributaries down. The radial nerve is sort of cutaneous, so the skin and touch for the posterior arm, and then for the anterior forearm, we're worried about the median nerve and the ulnar nerve. The median nerve runs in the middle, makes sense. The ulnar nerve runs on the ulnar side. That's how you remember that. The median nerve is going to the hand through this thing called the carpal tunnel. That's going to come up later, but it can get impinged here, cause a lot of pain. And like fractures right here, distal radius fractures can disrupt this neurovasculature. That's why you need to be aware of it. Sometimes if you see somebody fixing or reducing the fracture, they might have a Doppler out just to listen to these arteries, make sure they're still flowing. So you want to be aware of these structures. The musculature of the forearm, it's tricky, but it's fun. So I sort of put it on here. These are this is the flexor group. It goes PF, PF. The pronator teres is going to help you pronate. So that's when you internally rotate your wrist. That's the pronation, and externally rotating, it would be the supination. There's a flexor carpi radialis, which makes you flex your wrist to the radial side, to the thumb side. There's a palmaris longus. You can feel that tendon at your wrist. If you palpate it, 15% of people don't have it. Maybe you learned something about yourself today. There's a flexor carpi ulnaris, which is going to make you flex towards the ulnar side. These are the superficial muscles. So if you go a little deeper, it's the flexor digitorum superficialis, which is in green here. The other I just covered. And this is going to, if there's 3 bones in your finger, it's going to the middle one. It's going to the middle phalanx. So the superficial flexor digitorum is going to flex your finger, but only the middle bone. So that must mean there's a flexor digitorum profundus. These are the answers there, by the way. The flexor digitorum profundus is going to take care of that last finger bone. And the way to remember that is deep goes distal. So the deeper muscle, the profundus means deep, is going distal to the distal phalanx. There's 2 other muscles in the deep layer. The flexor pollicis longus. The thumb's kind of its own thing, and it's called the pollicis. So it has its own flexor muscle. And the pronator quadratus, like the pronator teres, is helping you do the pronation motion. I just wanted to end quickly with a quick preview of what we're talking about today. You should be able to tell what we're looking at here. We're looking at the wrist. The bigger bone is the radius. Looks weird here. That's a radial fracture. Looks even more obvious like a fracture from the side view. We can see here, this is an oblique fracture. And we're going to get into sort of how these get fixed. Quick terminology I noticed going through the papers is that this is the volar side. It's also the anterior side. And this is the dorsal side. It's also the posterior side. Radial is where the thumb is. Ulnar is where the pinky is. And that concludes my portion.
Thank you, Usman. So now that we have presented the anatomy, if anyone has any questions at any point, please feel free to ask. And I'm just going to run through it so the M1s have a better sense at how this progresses, but we'll now go into the 4 papers that each student will present, and there'll be discussion after each paper. But if at any point there's questions, you could put them in the chat or at the end, just ask the speaker.
Just one quick point, just for pronunciation of so capitellum is how you pronounce that part where the radius articulates with the elbow. Okay.
Good to know. Thank you, Dr. Monica.
So I think Bobby, your paper is next.
Sorry about that. Can you guys see my screen now? Cool. All right. So I'm going to be presenting this paper by Dr. Rosenthal and Dr. Blazer, published in 2006, about the outcomes and complications with volar plates for dorsally displaced distal radius fractures. A little bit of background. So when it comes to surgically fixing distal radius fractures, some common methods include percutaneous pinning, external fixation, or ORIF, and this One common option used to be, or are still, dorsal plates, but a problem with these is they tend to have extensor tendon tenosynovitis and rupture. And as an answer to that, volar plates were designed so we can place them on the other side and to hopefully avoid that extensor tendon irritation. So this was a retrospective review done at one institution. They found 49 consecutive patients who were originally fixed with, or they had distal radius fractures fixed with dorsal or volar plates. And of those, 41 had 1-year follow-ups that they decided to keep. So how they did it was everyone was initially closed or reduced and put in a splint. And then anyone who was deemed to have a unstable fracture pattern or could not hold their reduction went on to get an ORIF. When it came down to which implants were chosen, that was up to the discretion of the surgeons. And of the 41 cases, almost all of them came from the company Hand Innovations, and 4 of the cases were done with Synthes plates. The average follow-up for these patients were 17 months. And they were all placed in a volar splint right after surgery. And then at 1 week, they were seen in clinic and placed in a custom volar splint and allowed to actively move their wrist. And then after that, at 6 weeks, they were able to passively move their wrist. So the outcomes that they were looking at objectively were these functional outcomes regarding wrist flexion, wrist range of motion, and that included wrist flexion, extension, pronation, and supination. Those are all measured with a protractor called a goniometer. And they also measured grip strength, and that was measured with a dynamometer. These objective outcomes, the range of motion outcomes, were measured at the final follow-up visit for the study. Radiographically, they measured volar tilt, radial inclination, and radial height. And this image to the left kind of details how you take those measurements. And those measurements were done in the immediate postoperative period, and then when the fracture was found to be in union. So these are the results from the study. Functionally, on average, the volar plate patients got they had flexion at about 52 degrees, extension 53 degrees, supination 72 degrees, pronation 73 degrees, and the grip strength was about 94% of the contralateral side. Radiologically, radial height on average postoperatively was at 11.1 millimeters, and at union was found to have 11 millimeters. Radial inclination didn't change postoperatively to union at 21 degrees, and volar tilt was at 4 degrees postoperatively and found to be at 5 degrees at union. The DASH score, which is a score that stands for disability of the arm, shoulder, and hand, it measures how much it's a measure of like disability, a patient-reported outcome in terms of disability when it comes to the upper extremity. The lower the score is, the less disability that you're reporting. So it was 14 overall out of 100, and 12 out of 100 for the cases that had no complications, and 22 out of 100 for cases that did have complications. So the p-value was only 0.81. So going into the complications that they saw overall, the study had a complication rate of 22%. They categorized that into early and late complications. Early complications, they had 1 case of wound dehiscence and 1 case of a loss of reduction. The wound dehiscence came from a patient who also had a burn injury to the same side. And in terms of the late complications, they had 3 cases of loss of reduction that then went on to a malunion, 1 case of MCP joint stiffness, and then 3 cases of soft tissue complications. Those 3 soft tissue complications all required hardware removal. 2 of those cases were FCR tendinitis with FPL subluxation, and then 1 case was due to swelling with screw prominence. And on the left here, they had the images of one of these patients who had a loss of reduction that went on to a malunion. You can see in the top left corner, this was the first pre-op injury film where you can see, they have a distal radius fracture. In the top right, this is the pre-operative film where they pull the radius back out the length and they align the radius with the plate. And then later, they don't specify how or when this happens, but there you see a fracture around the site of the lunate fossa. And then the final image, this was taken at the last follow-up. So overall, this study, the results of the study support previous literature around that time that was starting to show that volar plates do have lower complication rates compared to dorsal plates. And compared to a previous study on dorsal plates that Rosenthal et al. Did, they found that volar plates had a lower rate of soft tissue complications specifically at 7% versus 32% for dorsal plates. So overall, they found that volar plates they're appropriate for most dorsally displaced distal radius fractures. However, comminution, especially along the dorsal aspect of the radius, may require some sort of alternative approach to fixing the fracture. And that's my presentation.
So Bobby, why do you think that one case failed there on that example you showed?
On this one? I think, I mean, they didn't say in the paper, but if I had to guess, it's maybe because there was the fracture kept falling out the back because of where the fracture was near the lunate fossa.
Yeah, so that could be part of it. Part of it is also, it's a pretty distal fracture, and there's a reason why they put the plate where they did. You try to put it a little proximal to the watershed line, which is where the most prominent portion of the volar radius is. But when you do that, and if the fracture is distal, then your screws are going to be in the fracture site, and that's probably what happened here. So they never really got good fixation. I also, they don't really have a lateral view, so it's hard to say exactly how the fixation looked, but this is one of the complications that can occur. And if you have a real distal fracture, then you just kind of have to put the plate more distally and understand that there will be a much higher risk of tendon irritation because the plate's going to be more prominent. So in those cases, you may want to counsel the patient that we had to put the plate distally in order to get good fracture fixation, but then we're going to watch you very closely and likely remove the hardware at around 6 months. Other things that you can do if you do have to put the plate real distal to get fixation is to repair the pronator quadratus over the plate if you can. That hasn't really been shown to be that helpful in any studies, but just from personal experience and seeing some other cases from my partners who repair the pronator quadratus and patients who have had distal and prominent plates, they do pretty well even if the plate is prominent with the pronator repaired, because it just offers a layer between the tendons and the plate. So.
Hey, Dr. Monica, that was a good explanation. And what's interesting here is that I think this was 2006 or 2007, and we're going to date ourselves, and I know this was done at Harvard, and probably you were there around the time that they were doing this. But I mean, honestly, this is now this is a historical paper because the volar fixed angle plate is relatively new. I mean, it's been around for probably 15, 17, less than 20 years. Can you maybe explain to the younger students like why this is such a big transformation in the way we treat these fractures?
Yeah, I mean, prior to this, it was basically pins and an external fixator or a combination of the two. Pins alone would probably be also with casting. And then obviously closed management. So with those fixation methods, obviously the patient's being immobilized for at least 6 weeks. So this volar plating really did change things, creating a locking fixed angle device that could allow for early mobilization was really a game changer.
Yeah, I agree. And Bobby, I thought you did a great job presenting that. And I think the key was when you showed those numbers that basically with these volar fixed angle plates, where you put that plate, the fracture seemed to stay. And that was something that we didn't have before because the bone was soft, or if you put people in a cast or pins, they would tend to settle down. But this was really the first device, you know, that you could put on, get people moving. External fixator, typically you couldn't, and the bone stays in place. So to me, I took that's the main thing I took away from this. And then again, some of the later papers will compare it to it, but volar plating, the fracture stays. And I don't know if Todd or Rob want to jump in and just maybe speak on their experience with plating some of these fractures and follow up and what they've seen.
Well, I think as residents now, we have kind of a unique experience that 99% of the distal radii that we fix are with volar plates. So we learn about the historical aspects of it, but we really don't learn much of even how to do it without a volar plate. So now, you know, now it's the gold standard. It's more of a thing where all the new surgeons coming out of fellowship are just so comfortable with volar plating that's mostly all they do.
Yeah, I agree with Todd. I mean, I haven't even seen dorsal plating, and I've been here 4 years. So I think for the most part, like all we do is volar plating, and it's just kind of. I mean, I think it's sometimes it's interesting. You'll see some older attendings do like, you know, a nice close reduction or percutaneous pinning with like, you know, kind of just like a 2-part bending type fracture, and it's always nice to like kind of hear like how those patients do, because we see so much volar plating, you don't even you don't even see the other ways to kind of, you know, treat some of these fractures. So I think in general, I mean, this is obviously a, you know, a big study back in the day, but it's that's kind of the standard of care for the most part.
All right, so we can move on to the next paper, which I'm presenting. So let me share my screen. So can you guys, well, it's not, let me. Can you guys all see that? Okay, cool. So the paper I'm presenting by Costa et al. In 2014 compares volar locking plate fixation with percutaneous fixation with K-wires, which is one of the other ways you can reduce the fracture, as Bobby had mentioned. So this was a randomized controlled trial that took place in the UK. It was a multi-center study enrolling 461 adult patients, and all of the distal radius fractures were dorsally displaced. The fractures had a displacement that was within 3 centimeters of the radiocarpal joint. If it was greater than that, they were excluded from the study. Other exclusion criteria were if it was greater than 2 weeks post-injury, if the articular surface could not be reduced indirectly, or patient was unable to complete the questionnaire that they used to measure their outcomes. Their outcomes that I'll get to in a little bit, but were basically how their wrist functional status was. So they randomized patients with a 1-to-1 treatment allocation by center. So the groups were chosen based on center. So one center would be assigned to treat with a K-wire, the other with a volar plating. And then they also decided to stratify the groups by age and by intra-articular extension of the fracture, as they thought these were 2 variables that could affect the bone quality. So age was over 50 and under 50, and then if not, there was intra-articular extension of the fracture. There was no blinding of surgeons or patients because that would be impossible, but the outcome assessors were blinded. So when they received the data from the patients, those that were inputting the data and recording it did not know which group the patients belonged to. And as I mentioned, the intervention was either K-wire fixation or locking plate fixation using a volar plate. So the outcomes were collected by postal questionnaire at baseline, 3 months, 6 months, and 12 months post-operatively. The primary outcome the authors wanted to look at was patient-reported risk evaluation. So this is a self-reported questionnaire that looks at the experience of pain and disability in the patient 0 to 100, 100 being the worst score. So you have less wrist functionality if you have a higher score. And then secondary outcomes they looked at is the DASH score, 0 to 100 again. Bobby talked about this a little bit, but again, higher score is worse disability. An EQ-5D, which is a quality of life questionnaire. And then if there were any complications such as refracture, neurological injury, vascular injuries, tendon injuries, wound infections, or and I think that was just about it. So the results. So if you look at this table, it has that primary outcome of the patient reported wrist evaluation score on the side. We said higher is worse. So at baseline, it is 0. Their wrist score would have been with no deficits. But 3 months post-op, it is higher in about the range of 30 to 40. And then as recovery progresses, the score goes down, which is a sign of gaining wrist function. But as you can see here, there's not that much of a difference between K-wires and plating. And so that's what the authors found, is that there was no statistically significant difference in this patient-reported wrist evaluation for at any time point and overall. So again, in the raw data, looking at all participants, and even when you're taking into consideration those stratifications of age and intra-articular extension of the fracture, there was no significant difference between the groups. The authors had said that if there was a score of, I think it was 6 points, that's a sign of different functional differences when you look at that patient-reported wrist evaluation. So not only was it non-significant, but there's no 6-point difference between the scores. And then this is again reflected in the secondary outcomes at 12 months, the DASH score and the EQ-5D. There's no difference between groups. And then if you look at some of the other outcomes, such as complication rates, again, no significant differences. The only thing they did find is that K-wires had higher use of casting after operation and therefore plaster change after operation. That just comes with how that fixation mapping is done. So they did report that as a finding. So again, no clinically relevant advantage of plates versus K-wires at 3, 6, or 12 months. While there was a lower DASH score at 12 months and a lower patient-reported wrist outcome, there was reported as not significant. There was no evidence of interaction between age group and treatment, even though they did those stratifications. Again, non-significant in complication rates. And they also reported that K-wire fixation is a quicker method. There's a median difference of 31 minutes in the operations. And conclusion that they said is locking plates offer no advantage over the older and cheaper method of K-wire fixation for patients with dorsally displaced fractures of the distal radius. So that difference that they found in DASH score was below clinical relevance. They said for patients that it was found at 12 months post-op was not significant, because the advantage of the volar locking plate is supposed to be that the patients can move the wrist earlier on in recovery. And they also reported K-wire fixation as quicker and that there's less perioperative antibiotics used. So they reported 71% of patients versus 83% in the plating group. Limitations to the study is that there were 46 participants with missing data, but the study was well powered. So they recruited more than they needed for an adequate statistical analysis. So that is a limitation in a way, but not necessarily. Impossible to blind patients and surgeons is just the nature of the study. And one thing that they did not look at is overall long-term complications, such as the development of arthritis. It was not followed. That would need to be a longer-term study to do so. And that's my presentation.
What was the follow-up time again for this?
3, 6, and 12 months.
Okay.
Yeah, I was just going to ask, is 1 year significant enough for a study of this size? I know like a lot of outcome studies, they want at least 2 years of follow-up data. I don't know if that would have made a difference in this study. That's just my thought when I saw the results.
So these authors actually do a follow-up study that came out somewhat recently in 2019, where they have up to like 5 years of follow-up data. And kind of one of the main critiques of this study was that they didn't really see if there was like post-traumatic arthritis that developed in these people that got K-wires. But in that follow-up study 2019, they actually found that they didn't have significantly more post-traumatic arthritis even at 5 years or worse outcomes than the volar fixed group.
I had one issue with this study in that in their patient selection, one of their criteria was that patients were excluded if the surgeon thought that the surface of the wrist joint was badly enough displaced to require open reduction. So it kind of felt like they were cherry picking cases for this to me. And I feel like you can, there's so much literature on these fractures that if you went and found, if you knew nothing about this and you asked me to find you 100 papers showing that K-wires are the best fixation, you could do it easily, and same for any other fixation. I feel like a lot of times these people who like to do whatever fixation they like to do have already chosen their result prior to even doing the study.
I agree with you, Todd. I think it is interesting that it was, up to the surgeon. I just, in personal experience, and anyone else maybe that can echo this, I find that pinning, I used to reserve for the older patient that just wanted, that needed an improvement in reduction, but didn't want to subject them to that much of an OR time, and they didn't mind casting afterwards as well. But I find it's very dependent on bone quality and fracture pattern for stability, obviously. So, in my little experience with pinning in older patients, that the reductions really did not hold, even with splinting and cast immobilization afterwards. So, that kind of just made me switch altogether to volar plating.
I think that I completely echo that sentiment. And I think what it is, like the first paper, the Rosenthal paper, once you put the volar plate on, you're done. I mean, Todd's doing a study now to look and see if even the splint after surgery matters. But in good bone, volar plates on, basically your interaction with the patient is pretty much done. God forbid they get a complication, which is really, really low. But if you put pins in there, the game still goes on. And it's, checking them in the office at 10 days. It's looking at the pin sites. It's additional casting. It's the stiffness afterwards. I mean, there's a lot more variables that you can eliminate all of them with putting a plate on. And I'm not saying that's the right answer, because obviously there's a higher cost because you're using the implant. But for a busy doctor, it certainly makes me sleep a little easier when I leave the operating room with stable fixation. Todd or Rob, do you guys, pin most of these? I know Dave Kirschenbaum talks about it a lot. Have you gotten much experience with him fixing fractures this way?
I've never been in a case with Dr. Kirschbaum who pinned a distal radius.
I've done 2 distal radii with Dr. Kirschenbaum, and they were both volar plates.
I agree with Dr. Monica. I think I would think it depends a lot on the bone quality. I mean, I haven't done very many, but I think it depends on the bone quality. I also think this kind of just emphasizes the point that, obviously if you have an acceptable reduction, especially for an older patient, like they don't have any real clinical differences, whether or not you're fixing them versus if you're accepting a, not perfect reduction. And I think that's kind of it's not the same concept here, but if you're thinking about patients who you're pinning and they're kind of losing a little bit of that reduction, and then a year out, they probably don't look radiographically as good as those who you volar plate, but their clinical function scores and their DASH scores are basically the same. It's kind of just reiterating that same concept that, accepting a little bit of deformity in an older patient. I don't know exactly what the average age of these patients were, but if they're on the older side, then you're going to have like the same functional scores for the most part.
Also, going back to that last paper, it was also 15 years ago. So even the complications that they had in that one, I think that the experience that people have with it now and the different options for fixation, that I wouldn't be surprised if you would get less of those complications.
Yeah, I 100% agree with you. The other thing, Christina, is a lot of the patients they put the plate on still ended up getting post-operative immobilization, and they didn't say how long that was. But if they got a plate and then were casted for 6 weeks, I imagine they would do very similar to if they got pins and casted for 6 weeks. Whereas with these volar plates, a lot of times minimal splinting, and at 6 weeks, they're basically done, as opposed to 6 weeks coming out of a cast and 3 months of physical therapy. is really tough on the patient and you as the provider to watch them struggle through it.
So I think next up is Jared.
Can everybody hear me? So I think the conversation we just had is a nice segue into my topic, which looks at sharing. Sorry, guys. Oops, sorry, the system just booted me off. I'm bringing it up now. All right, is everyone able to see it? Okay, cool. So, so my topic is going to be on distal radius fractures in osteoporotic patients. So the study I looked at is called Aspects of Current Management of Distal Radius Fractures in the Elderly Individual. This was done in 2011 at the Department of Trauma Surgery and Sports Medicine, the Medical University of Innsbruck in Austria. So just as I know that we have a mixed bag of patients between M1 and residents and attending. So osteoporosis, just as a quick run through, is a systemic skeletal disorder. Patients tend to have low bone mass and bone density due to deterioration of bone tissue, which leads to increased bone fragility and fracture risk. So in older patients, osteoporosis is a common cause of fractures. And in this particular study, we're looking at distal radius fractures as a result. So introduction, distal radius fractures are common fractures in people with osteoporosis. I just want to make the note that every time I talk about any patients, we're talking about osteoporotic patients and the elderly population. So this does not apply to younger patients. Traditionally, this study was in 2011, so I'm guessing years before that. DRFs were treated with closed reduction cast mobilization in elderly patients. If the fracture reduction couldn't be maintained, then additional type of fixation was suggested. Often the decision to treat was based on data presented with younger patients, and with a growing population of elderly patients, it's becoming more and more important to determine appropriate management of these type of patients. This paper is a review article. It goes through a number of different options for distal radius fracture treatment, and just kind of goes over the different studies that talked about them. So just as a kind of coverall, the assessment of instability. So when you have a distal radius fracture, the recommendation is to reduce under local general anesthesia in the ED and then immobilize. In primary reduction, we determine that the fracture has been reduced if the dorsal tilt is less than 20 degrees, radial shortening is less than 3 millimeters, and intra-articular step-off is less than 2 millimeters. Fracture instability is a loss of this reduction at one or 2 weeks. So treatment options that the study goes over, you can see closed reduction, cast mobilization. Step up from that, closed reduction, percutaneous pinning, external fixation with either bridging, non-bridging NK wires, or open reduction with the volar locking plate fixation, which has been the last 2 studies have talked primarily about. So this study looked at closed reduction cast mobilization. The patients were immobilized for 6 weeks in an elbow cast. There was no difference in results between long and short arm casts. The study noted Young and Ryan, as well as Bumer et al., that found no correlation between unsatisfactory radiographic results and functional outcomes in 26 patients. There were a few risks that did result in joint arthrosis, but only 2 out of the 6 patients that developed arthrosis had unsatisfactory clinical outcomes. Negatives of casting. So casting does not hold the reduction well until the bone union forms. So in the situations with elderly patients, per the study, nearly 50% of these patients put in casts and immobilizations result in non-union of the bone. So our next topic, it would be closed reduction percutaneous pinning. So the various approaches that they talked about were pins through the radiostyloid, cross pins entering the dorsal cortex, and intrafocal pinning through the fracture site. This the X-ray on the left came from the study. As one of the patients that had pinning through the radius and the ulna. So K-wires are not a load-bearing device, so they do require casting. The patients aren't able to be pinned and then left. They have to go through casting. So the wires are left in for about 4 weeks and casting for 6 weeks. And this is primarily recommended for reducible extra-articular and simple intra-articular distal radius fractures. As a party, studied 57 patients that were older than 60 years old with unstable extra-articular fractures. And what they found was forearm casting alone versus percutaneous pinning improved radiographic parameters, but as far as clinical results are concerned, it's all the same. And I know that we kind of just talked about this, and it's going to be a common thread through much of this study, but really it improved radiographic results. But as far as the patient's report with pain, range of motion, grip strength, all of them, there was no difference found. So it concluded that improved radiographic parameters but offered no support clinically. And then McQueen had similar results. This is, again, the photo comes from the study. This is an example of external fixation with bridging. You can see that there are screws going through the metacarpal as well as the distal radius going across a joint, which is what bridging means. So this is reserved for highly unstable and severely comminuted fractures. It relies on what we call ligamentotaxis, which is by indirectly pulling the fracture fragments out to length through longitudinal traction. So like I said, bridging spans the joint. However, bridging does not address reduction and maintenance of the dorsal tilt and intra-articular fragments. Ruman found that if comparing external fixation versus closed reduction and immobilization for patients over the age of 55, again, improved radiographic results. But as far as clinical outcomes and functional results, there was no difference found. So now we have external fixation non-bridging, meaning it does not cross the joint. So in this case, there's distal, the distal pinning goes, or distal screwing goes through a distal fracture fragment without spanning the wrist joint. This limits joint stiffness, maintains the reconstructed dorsal tilt, and however, you do need sufficient enough space in the distal fragment. So if that distal fragment isn't large enough, you're not able to use this approach. Atroshi et al. Studied non-bridging technique versus the bridging technique. Radial length was better with the non-bridging technique, but no difference in functional results. And then external fixation with the addition of K-wires. Again, this was studied with comparing external fixation and buttress maintained pinning method in patients over 65 versus younger than 65. In this case, neither radiographic nor functional results were any different between the comparisons group. And I don't know if we talked about it, but K-wires also include complications such as pin track infections. In this case, could be lesions of the superficial radial nerve, as well as Dr. Cott mentioned before, that later the patients do have to come back because the pinning needs to be taken out. So now we talk about open reduction, ORIF, and the volar locking plate fixation, which is what we've talked about in the last two cases. So distal radius fractures are primarily hyperextension injuries. And again, this study was in 2011, and as we've kind of been discussing, this dorsal approach is rarely even seen anymore, and primarily we've used the volar approach with with the locking plate, but the study still talked about it. So traditionally, I suppose dorsal approaches with a dorsal buttress plate were the procedure of choice, came with a lot of complications, including extensor tendinosynovitis and tendon rupture, as well as the additional need for metaphyseal support like bone grafts and bone substitutes. So the volar approach is now the preferred method for patients. They did note that this is the preferred method for patients that have failed conservative management. It helps to increase mechanical rigidness, as well as the bone grafting became redundant and unnecessary. So this is an example of the volar locking plate. In picture A and B, you have the distal radius fracture. And then in C and D, you have a radiograph evidence of the volar blocking plate. So again, this was studied by Jupiter et al. And Eagle et al. And what Jupiter found was that in evaluating 20 patients less than 60, they did have good follow-up at average at 38 months, 7 excellent, 11 good, and 2 fair follow-up results reported by the patients. And then Eagle et al. Found that in comparing outcomes for patients greater than 65 treated surgically versus non-surgically, so surgical patients tended to do better radiographically, and they did have better wrist extension, grip strength, and radiographic results. No difference in complications. However, at 1 year, the loss in grip strength and minimal range and motion loss did not limit functional capacity. In the DASH score, which is the disability of the arm, shoulder, and hand at pain scores, there was no difference between surgical and non-surgical at any time throughout the follow-up period. So the conclusions of the study, cast with mobilization was preferred method until the development of the volar locking plate. Volar locking plate has superior stiffness, axial loading strength, but has a higher complication rate, which would be interesting because I know we just talked about the very low complication rates. This might be due to the study having been come out almost 10 years ago, 10 years plus if you count in the the work done prior. And then poor correlation between radiographic and functional outcomes in all these older patients. So basically, these older patients, you get better radiographic evidence of healing in the patients. However, functional outcomes are no different. It could be just due to the fact that the patients are older and the functional demand on the wrist is just not as great as it is in younger athletes or younger patients or athletes. So, and then from the patient's point of view, pain is the primary outcome, and non-operative was reported as the best pain outcome. And then improved radiographic outcomes do not correlate with improved function. So the final recommendation of the paper, if there's no significant difference between functional outcomes in long-term after non-surgical or surgical, then really it comes down to indications of surgery factors like the age, patient's comfort, lifestyle requirements, current medical conditions, stage of osteoporosis, and they should all be included in the decision-making process as far as taking the patient into surgery. And that kind of sums up anything. Any questions?
Jared, I thought that was really good. One point I want to make, and you showed this in terms of the Jupiter results, and then in Christina's paper earlier, these patients, they don't go to zero. And, as a provider, that's real, right? And if the average is 7 or 10, and that's pretty low on the DASH score, but they're still not normal. And I think you just have to kind of get over the fact that, people are going to have, even if it's mild, but some degree of impairment after a devastating injury like this, even with the best fixation.
So also to that, I might add that the dash. I think this used the dash. I think one of the things that the dash asks is if you can touch your back, like wash your back. And in my experience asking that question, a lot of them will say, oh no, I can't do that, but that's not because of my hand or my arm. That's because my shoulder is really stiff. So especially in elderly patients, like a base level of, like 10 on the dash was actually, I think, pretty like standard, unfortunately. So like you were saying, a lot of them I don't think ever returned to complete zero, but that's kind of,
That's a good point, that they may not be all starting at zero either.
yeah.
So one thing I would have liked to know, they gave us the radiographic outcomes for the non-operative group after closed reduction, but we don't know what the operative group's radiographic results were before surgery. We only know what they were after surgery. So I can't even confidently say that the patient populations had similar reductions prior to surgery, which I think definitely greatly affects your choice in treatment.
That's all for that one. Then Karen, you can present your paper.
Can you guys see that? Perfect. Okay. Okay, so I will be presenting. Hi, I'm Karen. I'm a second year medical student. I'll be presenting non-operative treatment compared with volar locking plate fixation for dorsally displaced distal radius fracture in the elderly by Saving. Just I think some of the other presentations had really good background, so I'm not going to go into too much detail, but what's kind of unique about this study, I thought, was that it was done specifically for elderly patients. A big difference between DRFs and elderly patients is that they tend to be lower energy mechanisms, the most common being falling onto an outstretched hand. So dorsal displacement is very common. And like other people have mentioned, rates of like osteopenia and osteoporosis are higher. So that definitely is a consideration. So kind of this, the jumping off point for this study that this authors kind of note is that the usage of volar locking plate fixation has increased in older patients, despite lack of evidence that surgical treatment is better than non-operative treatment. So that was kind of just the basis of that study, or the reasoning for their study. Really quickly, the study population was patients who were 75 years or older, but they reduced that recruitment age to 70 to kind of boost their recruitment numbers, which is a point of weakness that I'll touch on a little bit later. And they also do look for wrist radiograph of greater than 20 degrees of dorsal tilt, so dorsally displaced. Again, like another consideration that this population is important to, I think about when we think of distal radius fractures, because elderly patients, nowadays they're living longer and they're leading more active lifestyle. So before, I think it was incorrectly assumed that, oh, this is an elderly patient, they're probably not going to use their arm as much. So even if there were functional deficits, it wasn't as important, they thought, to address it. But now we know that that's not true. So there are more studies, I think, focusing on specifically elderly populations. So the methods, I'm just going to quickly list a few of the flaws, I guess I saw. So they recruited from 2 different hospitals, which did have some differences in recruitment methodology. So as I mentioned before, the inclusion criteria was lowered to 70 for hospital S. There are 2 hospitals and the names are very long and like Swedish, so I'm just gonna abbreviate them. But hospital S excluded intra-articular fractures with a step off of greater than 1 millimeter or a gap of 1 millimeter, but hospital D did not. Hospital S used the PRWE and hospital D used the DASH score as their primary outcome measure, and both hospitals use slightly different implants. These are just things that were noted in the paper as in the method section. I'll just also touch on why I think these are okay things to kind of not let slide per se, but just it's okay. This slide, I just wanted to highlight that even though the hospitals were recruited at different hospitals, they were each randomized. So there were patients in each treatment group from both hospitals. So we couldn't say, like, that's not a weakness there. Sometimes when you have, one hospital treating with a certain way and a different hospital treating a different way, you can kind of say that, maybe you had different patient populations, or maybe there were more experienced surgeons at the other hospital, but that's not the case here because both groups had patients from both hospitals. The primary, these are just kind of, this is just a summary of exactly what they did. I bolded what's kind of mainly different. So they did standardize their treatment protocols, which was great. They put them in a dorsal plaster splint for 2 weeks post-op. So one quick note here is that the surgical group did have slightly earlier mobilization, even taking into account like the 2-week gap within, so sometimes they did the surgery within 2 weeks, like not the day of. So even taking that into account, these patients did have some earlier mobilization, which could explain some of the improvements, but they will also touch on that at the very end. Outcome measures, they primarily focus on patient-reported outcome measures, which I thought was another unique feature of the study. Again, one hospital used the PRWE and the other used DASH, but both are validated measures for distal radius fractures and upper extremity problems. So that the authors kind of say that that's why they don't think it's a problem that they use slightly different ones. With that though, there is one note that the DASH, the clinically significant like improvement, I believe is 10 points, but for the patient rated risk evaluation is like 6 points or 7 points. But they do account for all of that in the statistical analysis. Okay, getting to the results. So this is just to show that the patient-reported outcomes, the PROMs, were lower in the volar locking plate group. Those are the 2 images on the left. And lower score, I think it was said before, indicates less disability. This, I'll go over the statistical significance of it. This is actually slightly not statistically significant, but barely, so it's a little ambiguous. Grip strength increased with the volar locking plate, which is what we're looking for. We want more grip strength. So yeah, so the red boxes are where it's not technically statistically significant, but if you look at these numbers like 0.002, they're close enough to statistical significance that I think they are valid kind of conclusions that the PRWE and DASH score improved, and that was at all follow-ups, which is 3 months and 12 months primarily. Radiographic outcomes, unsurprisingly, were completely statistically significant when it came to the improvements. We expected that, but as it was mentioned before, radiographic outcomes don't necessarily correlate to clinical outcomes. So while this is great, we don't know if this actually means that the procedure is better per se. Rates of complications, I just added in the values for statistical significance. They found none. But if you do kind of look at like what kind of complications you have, the overall rate was not very different. There's similar rates between the two, but if you're looking at things like nerve numbness, there is more of that in volar locking plates, wound infections, scars. Those are kind of bigger complications that, even though they're minor, like to the patient, they might matter more. Like nerve pathologies are notoriously like very uncomfortable to deal with. So even though the rates were the same, that could just be an additional consideration. So this is like a very simple summary. Basically, the patient-reported outcome measures were better in the surgical group. The radiographic measures were better in the surgical group, and complication rates were similar between the 2 groups. So the authors conclude that volar plate fixation is better. So a few points of discussion. While the PRWE and DASH are validated upper extremity outcome measures, they're not validated specifically in elderly patient populations. This is still the best method that they have though, so we can't really, I guess, hold it against them for not having something different. I've given like the DASH before, and like I've mentioned, there are some questions that are designed, I think, for people who don't already have like existing shoulder stiffness, which kind of come naturally as you age. So if there were ever to be a validated outcome measure for specifically elderly patients, that could be a great addition. It did combine 2 separate studies, or 2 kind of recruitment events, I guess, at 2 different hospitals. It wasn't blinded. Like you said, it's not possible because you either do a surgery or you don't, or they have so that's not really possible. And another significant one is earlier mobilization of the surgical group. Dr. Alter and I are actually doing a study on whether early mobilization helps or doesn't. Does it help or not help with like stiffness and all of that? So that's actually an active area of study. And then in terms of strengths, fairly large sample size that is representative of the patient population. There were only 2 patients that made crossovers into from non-operative management to surgical management, which is really, really good. And then the radiologists and occupational therapists that did all of these ratings were independent from the study, even if the surgeons were not. So those are some strengths. And I believe that is it. I'm gonna stop sharing really quickly. Any questions, comments?
So it's kind of interesting that the outcomes measures aren't validated in elderly patients, and that's kind of one of the major outcomes measures that we look at, the DASH score and the PRWE. So how much, closed management affects elderly patients may not really be known as well. I mean, we've always been, all the literature points to elderly patients accepting more deformity, but maybe it's just because, like you said, those outcomes measures aren't exactly that accurate in that age group.
Right. I mean, when the outcome measures are done, they do include a very wide range of patients, but just from like personal experience, having asked some of these questions, like I said, like a lot of them have like existing kind of shoulder discomfort and stuff. And a lot of the questions are purposely vague about that. They'll say like, do you have any discomfort, or, a little bit, so it doesn't, and it also doesn't count for like handedness and all, a lot of things. So these measures, I think, are all inherently a little bit flawed. But again, it is kind of the best that is available. So it is still meaningful, maybe just not like a perfect measure of outcomes.
Yeah, I think it's really important to just take each patient as an individual and really assess their functional status the best you can, and mental status, for that matter, activity level, to really try to make a decision, and not necessarily, put them in a elderly over 65 group.
Right. Oh, actually, one more weakness that I forgot to mention is nowhere in the methods did they talk about like patients that might already have like osteopenia or osteoporosis. So that wasn't like an exclusion criteria, that wasn't in the discussion at all. And I think that that they likely just didn't have the data for it, but that could be a worthy inclusion if we're looking at actual, like outcomes, and an important consideration for especially the elderly population.
So Amber, you just got back from your away rotation at Beth Israel Deaconess. How are they fixing distal radius fractures in the elderly there?
A lot of it actually is taking a big look at how, like, these patients, like what their status is at baseline. So like you'll see one patient who could be like 65 with severe dementia, dependent patient, and then you can cast that patient. But at the same time, you can see someone who's close to 90, but like still working job and like taking care, like doing multiple activities. For them, a lot of times, both of the main attendings there were treating most of those kinds of patients while they're walking in place. So it is really taking into account like the specific patient that you're seeing ahead of you and their sort of baseline functional status. I think one also interesting thing is there's this online program called RICALC from the Edinburgh Trauma that just looks at a few different things other than patient age, like ulnar variance, dorsal comminution, and just like leaving all those boxes unchecked, just by putting the patient age at 65, their risk of redisplacing or going on union treatment is already over 50%. So just something interesting to find.
So let's hear from a couple of the M1s. Just maybe throw out something if you feel comfortable speaking. Just maybe something you've learned tonight, or something you didn't know that you want to follow up on for later on. And feel free to put it in the chat box as well if you'd like. And that's okay. You don't all have to talk at once. So PJ, have you done a risk reduction yet?
No, I haven't done one at Jersey City. I was mostly with, I mean, trauma does risk too, but I saw a lot of knees, a lot of hips, and a couple scopes for like ACL tears or meniscal tears. But yeah, I really haven't seen any like hand surgery. I was really on the big joints, so like hips and knees. So I'm just learning about this, and like research and journal club is really nice. But I see a bunch of x-rays of it. I just haven't seen it in the OR yet.
Awesome. Well, I just want to thank everybody that volunteered to present. I thought those presentations from Usman's all the way through were just fantastic. So it was, and just the turnout tonight was really incredible. So I'm glad there's this much interest in the, you know, younger classes for orthopedics, and for the residents that came. I thought that was really cool too. So thank you everybody for being here, and Christina for organizing everything.